Usually when we talk about a medical diagnosis, there's this expectation of like clinical precision.
Oh, absolutely.
It's almost like engineering, right? Like if you break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, there it is. That's the problem. We'll fix it.
Yeah, it's comforting because it's a binary. The bone is broken or it's not. The fix is physical and, immediate.
Exactly.
Yeah.
We really like things to be visible and neatly categorized. But then you look at modern cancer treatment, specifically pelvic radiotherapy, and that illusion of a clean, perfectly targeted fix just kind of shatters.
It really does.
In the sources we're looking at today, we're talking about delivering like 60 to 90 gray of radiation to eradicate cervical, endometrial, and anal cancers. And let's be clear, I mean, it works.
Right. The technology is incredible at saving lives.
It is. But that survival often comes with a silent, honestly agonizing cost that nobody outside of the patients and their oncologists really talks about.
It's a profound paradox in modern oncology, to be honest. We have these highly effective curative therapies, but the collateral damage to the surrounding healthy tissue is, it's devastating.
Yeah.
For many cancer survivors, the aftermath is completely life-altering, and the medical system hasn't entirely caught up to managing that survivorship phase.
And that is exactly our mission for this deep dive. We are exploring a highly painful, incredibly underdiscussed condition called post-radiation vaginal stenosis. Basically, for those of you listening, this is a condition where the vaginal canal narrows, shortens, and in severe cases, completely obliterates following radiation therapy.
It's a brutal reality for a lot of women.
It really is, and we've pulled together a massive stack of sources to figure out what's going on here. We've got standard of care oncology guidelines from EVQ, alongside cutting-edge regenerative medicine papers from MDPI, Frontiers, and PubMed.
And we are going to look specifically at how the future of healing this condition doesn't lie in the mechanical physical tools we rely on today, but in microscopic cellular cargo ships called exosomes.
Which is wild to think about.
Right, we're moving from a mechanical approach to a purely biological one.
Okay, let's unpack this. Before we get to these cellular cargo ships and how they use growth factors to literally command the body to regrow dead blood vessel networks from scratch, we need to set the stage.
Yeah, you have to understand the problem to fix it.
Right. So what exactly is that 60 to 90 gray of radiation doing to the tissue to cause such severe scarring in the first place?
Well, the best way to look at the damage is chronologically, because radiation doesn't just, burn the tissue and stop.
It's not a one-and-done thing.
Not at all. It sets off a cascading chain reaction over months and years. In the acute phase, which typically peaks around the 4th week of radiation treatment, the patient experiences severe mucosal inflammation and ulceration.
Okay.
But the most critical damage is happening a layer deeper. The radiation causes a massive depletion of the basal layer.
And the basal layer is essentially the nursery, right? Like, it's where the stem cells live that are responsible for constantly regenerating the vaginal lining.
That's the one. So the very cells whose entire job is to heal the tissue are wiped out right at the start of the trauma.
Wow.
Yeah, and then over the following months, the tissue enters a chronic phase. Because those regenerative stem cells are gone, the body basically panics.
It just doesn't know what to do.
Exactly. It tries to heal these lingering ulcers with whatever tools it has left. And the fibroblasts, which are the cells that usually build flexible, healthy structural tissue, they actually mutate under these conditions.
Oh, they mutate.
Yeah, they turn into what are called post-mitotic fibrocytes. Instead of building a healthy matrix, they start depositing dense, irregular collagen and fibrinous scar tissue.
Let's visualize that for a second. It's kind of like finding a tear in a delicate silk shirt. Because you don't have any silk thread left, you just, start patching the hole with thick, stiff strips of duct tape.
That is a great analogy. And you just keep adding duct tape over and over. Eventually, the shirt loses all its flexibility.
Right.
In the body, this leads to circumferential fibrosis, which is the physical narrowing and shortening of the canal. But even more critically, it leads to severe ischemia.
Ischemia meaning a total lack of blood flow.
Yes, the tissue is completely starved.
Which brings us to the current standard of care.
Yeah.
I was reading through the AVQ guidelines, and I have to say, it sounds incredibly brutal.
It's not easy for the patients, that's for sure.
The official guidelines suggest that once the acute inflammation has resolved, usually about 4 weeks post-radiation, patients are instructed to use hard plastic vaginal dilators. They are told to insert these rigid plastic or silicone rods, often 3 times a week for 5 to 10 minutes, to manually stretch the tissue and break up the scar adhesions.
The clinical rationale behind this is entirely mechanical. The medical field is essentially trying to forcibly maintain patency, keeping the canal open, so that patients can continue to have pelvic exams for cancer surveillance.
Which is obviously important.
Right, and ideally maintain sexual function too.
I understand the goal, I really do. But looking at the biology we just discussed, I can't help but push back on this approach.
Go for it.
You've got tissue that is completely starved of blood. It's heavily fibrotic. It's essentially dying. Using a hard plastic dilator on that tissue feels like taking a dried out, cracked leather belt and just aggressively pulling on both ends to stretch it.
Yeah.
Sure, you might physically keep it from shrinking completely, but stretching it doesn't make the leather alive or supple again. It just causes micro tears and damages it further. Why is the standard of care still relying on plastic rods when the problem is so clearly a cellular issue?
It's a frustration shared by a lot of researchers and patients, believe me. And you're touching on the exact reason why this treatment has abysmal patient compliance.
I mean, I don't blame them.
The guidelines themselves acknowledge that patients find this incredibly distressing. It causes bleeding, it causes severe pain, known clinically as dyspareunia, and the underlying biological issue isn't being addressed at all.
Right.
The radiation has created what we call a microvascular desert.
A microvascular desert. That is a bleak but, wow, accurate term.
The high doses of radiation permanently destroy the endothelial cells. Those are the cells that line the inner walls of your blood vessels.
Okay.
Without those structural lining cells, the capillaries simply collapse. There is no blood, no oxygen, no nutrients. The tissue is quite literally suffocating.
Yeah.
You cannot stretch suffocating tissue back to health.
But if you're listening to this and wondering, wait, the human body is amazing at healing itself. Like, if I cut my finger chopping vegetables, my body naturally grows new capillaries to heal it.
Sure.
Why doesn't the body just build new blood vessels in the pelvis? Why does this specific area become a permanent desert?
That is the core puzzle of this condition, and the answer comes down to a really specific structural vulnerability in human anatomy.
Okay, lay on me.
The lower third of the vagina, the distal vagina, is actually the most susceptible to necrosis and severe stenosis.
Which honestly seems completely counterintuitive. If someone is getting radiation for cervical cancer, you'd think the deeper tissue closer to the cervix and the radiation source would be hit the hardest.
You would definitely assume that. But the severity of the damage isn't just about proximity to the radiation beam, it's about the plumbing.
The plumbing.
Yes. The distal vagina gets its blood supply from the middle, rectal, and internal pudendal arteries.
Okay, let's unpack the plumbing. Why are those specific arteries so vulnerable?
Because they are what vascular surgeons call terminal branches of the internal iliac artery.
Terminal branches.
Think of a terminal branch like a dead-end street in a neighborhood. If a massive storm washes out the only bridge leading onto that dead-end street, the houses at the end are entirely cut off.
Oh, wow.
There is no detour. There is no backup route for the supply trucks.
Ah, I see. So if the radiation obliterates the endothelial cells in that specific terminal branch, the body physically has no alternate blood supply to route into the tissue. The bridge is out, and there's no other road in.
That's the reality of it. Revascularization, the body's natural process of building new blood vessels, is nearly impossible on its own in this specific region once that terminal branch is destroyed.
That is awful.
And to compound the issue, this area is right next to the rectum. So you have a tissue that is starving for oxygen, breaking down, forming open ulcers, and it's sitting right next to a major source of bacteria.
Oh, man. So the infection risk is huge.
Exactly. The risk of bacterial superinfections is incredibly high, which further halts any natural healing that might have miraculously started.
If you are a patient who has been through pelvic radiation, or even a clinician treating these survivors, understanding this anatomical fragility really changes your entire perspective.
It really does.
It completely explains why the damage feels so permanent and why a plastic dilator is never going to be enough. The body physically lacks the infrastructure to heal itself. We desperately need a biological intervention that can force the body to sprout new blood vessels from scratch.
And since the body cannot rebuild this terminal vascular network on its own, this is exactly where the frontier of regenerative medicine is stepping in with a completely different approach.
Enter the hero of our deep dives, mesenchymal stem cells. Specifically, adipose-derived stem cells, or ADSCs.
Right.
These are stem cells that are harvested from fat tissue, but and this is a massive distinction in the research, we are not talking about injecting live stem cells into the patient.
If we connect this to the bigger picture, it's a crucial distinction. Using live stem cells, especially in a patient with a history of cancer, comes with a lot of baggage.
What kind of baggage?
Well, there are ethical concerns surrounding certain types of stem cells. There are massive logistical nightmares regarding how you keep live cells alive during storage and transport. And most importantly, there is always the fear of tumorigenic risks.
Meaning the risk that a live dividing stem cell might get confused in a damaged environment and form a new tumor?
Correct. You are introducing cells that are programmed to multiply rapidly. In a cancer survivor, you want to be extremely careful with anything that promotes rapid, uncontrolled cellular division.
That makes total sense.
So instead of using the live stem cells themselves, the researchers use their exosomes.
Let's spend a minute here because this is fascinating. Exosomes are extracellular vesicles. You can think of them as tiny, microscopic biological envelopes that the stem cells secrete.
They are essentially the communication packets that stem cells use to tell other cells what to do.
Let's use an analogy. Think of a live stem cell like a fully staffed construction crew. If you drop a massive construction crew into a disaster zone, they might start building, but they take up a ton of space, they need food and resources, and if they misread the environment, they might build a skyscraper where you just needed a bridge.
That's a huge risk.
Right. Exosomes, on the other hand, aren't the crew. They are just the blueprints and the raw materials.
Yeah.
They get mailed directly to the site in these tiny biological envelopes. The local damaged cells that are already in the tissue open the envelopes, read the blueprints, and they do the targeted rebuilding themselves.
I like that framing. The exosomes completely bypass the risks of live cells because they cannot divide. They aren't alive in that sense.
They're just the mail.
They're just the cargo.
Yeah.
But it's what is inside that cargo that is truly revolutionary for treating post-radiation stenosis.
Let's look at the payload. What exactly is in these envelopes that can fix a microvascular desert? The papers dive deep into the specific growth factors. We've got microRNAs like miR21, miR100, and miR146A. And then the three heavy hitter growth factors that really stood out to me are vascular endothelial growth factor, or VEGF, basic fibroblast growth factor, or bFGF, and platelet-derived growth factor, PDGF.
And those three growth factors are the exact blueprint needed to cure the desert. When these ADSC-derived exosomes are applied to that scarred, irradiated vaginal tissue, they are absorbed by the few surviving, struggling endothelial cells.
Okay, the ones that barely made it.
Right. And inside the exosome is a trigger mechanism called AHIF, which essentially acts as an overriding command code.
So the struggling cell opens the envelope, reads the code, and what happens?
The code immediately activates the growth factors, specifically VEGF-A and VEGF-D, as well as bFGF. VEGF acts like a massive signal flare. It tells the endothelial cells, wake up, we need to build new roads right now. It initiates the sprouting of new capillaries.
Wow.
Then bFGF steps in to help support the migration and division of those cells, ensuring the new vessels have the right cellular support. Finally, PDGF acts as the stabilizer.
So the vessels don't just fall apart.
Exactly. It recruits other cells to wrap around these newly formed fragile capillaries so they don't just collapse again.
This entire process is called angiogenesis, the creation of new blood vessels.
Angiogenesis is the holy grail here. By forcing this microvascular network to reestablish itself using VEGF, bFGF, and PDGF, blood, oxygen, and nutrients finally flood back into the distal vagina.
That is incredible.
It reverses the hypoxia. The tissue can actually breathe again, which allows the mucosal lining to finally regenerate.
It's a huge shift in how we think about healing. We aren't just stretching scar tissue. We are fundamentally building new roads to bring food and oxygen back to a starving city.
That's exactly what's happening on a cellular level.
Well, hold on. Let's look at this critically for a second. We're talking about cancer survivors.
Right.
If you take a post-radiation pelvis and you flood it with powerful growth factors like VEGF and bFGF, whose entire biological job is to trigger massive blood vessel growth, aren't we risking feeding a microscopic cancer cell that might have survived the radiation?
It's a very valid concern.
Aren't we just building a high-speed vascular highway to feed a new tumor?
It is the most critical question in regenerative oncology, and the researchers focused heavily on this exact risk. The short answer is no, because of the specific nature of these exosome-derived growth factors.
Okay, why not?
They don't just act like a blind accelerator pedal, triggering reckless, unchecked growth. They actually restore tissue homeostasis.
meaning they bring the tissue back into a state of natural balance rather than just forcing it to grow forever.
Exactly. The exosomes act almost like an environmental cleanup crew before they start building. The research shows that while they promote targeted epithelial and endothelial cell proliferation, they simultaneously improve DNA repair.
Well, that's interesting.
Yeah, the radiation caused double-strand breaks in the DNA of the healthy cells. The exosomes upregulate specific genes like DDB2 and RNF8 that carry instructions to help the healthy cells repair those breaks.
So they're fixing the foundation first.
Furthermore, the exosomes actively scavenge reactive oxygen species, or ROS. That's the toxic debris left over from the radiation. They neutralize them using powerful antioxidants like SOD1.
So they are actively cleaning up the toxic environment first.
Yes, they are clearing out the toxic debris and repairing the genetic damage in the healthy cells. They are programming the tissue for controlled, healthy repair, not fueling the malignant, chaotic environment that a tumor needs to thrive.
Okay, that makes a lot of sense. So we've solved the blood supply issue. We've got angiogenesis happening, capillaries are sprouting, PDGF is stabilizing them, oxygen is flowing. But we still have a major physical problem. What happens to the existing stiff scar tissue? That mutated collagen we talked about earlier, the duct tape, is still physically narrowing the vaginal canal. New blood vessels don't just magically make scar tissue disappear, do they?
You're right. Restoring blood flow is only half the battle. We also have to remodel the matrix.
Right.
The tissue itself needs to be softened and cleared. The exosomes also interact with those dermal fibroblasts we talked about earlier, the ones that laid down all that dense collagen.
How do they fix the duct tape problem?
By reprogramming the immune system's cleanup crew, they downregulate pro-inflammatory markers like IL-6 and IL-1, and they alter the behavior of macrophages in the tissue. Macrophages are immune cells that can exist in different states.
Okay.
We generally categorize them into two types, M1 and M2.
Let me guess, one of them is the problem and one is the solution.
Precisely. After radiation, the tissue is flooded with M1 macrophages. You can think of M1s as the demolition crew. They are highly inflammatory, they cause swelling, and they promote scarring.
Got it.
The exosomes force these macrophages to switch from an inflammatory M1 state to a healing M2 state.
And the M2 state is the repair crew.
The M2 macrophages dampen inflammation and actually start clearing away the dense fibrotic debris. They stop the demolition and start the cleanup.
There was a really fascinating detail in one of the studies regarding a mouse model that visualized this cleanup process perfectly.
Oh, the hyaluronan study.
Yeah. It focused on the balance of hyaluronan, or HA. The wound repair process in the body is basically a biological tug of war between two types of HA. You have low molecular weight HA, which acts like an alarm system, triggering inflammation and telling the body to lay down quick, messy scar tissue.
Right.
On the other side, you have high molecular weight HA, which dampens the alarm, stops the inflammation, and promotes true structured regeneration.
And radiation heavily skews that tug of war toward the low molecular weight HA. The tissue is stuck in a permanent inflammatory panic.
Right. And the exosomes step in and pull the rope the other way. They push the tissue back toward producing high molecular weight HA, restoring the balance and turning off the alarm.
And we have tangible proof that this two-pronged approach, using VEGF and bFGF for blood vessel growth and switching the macrophages to remodel the matrix, actually works in a living system.
Tell me about the proof.
The sources detail a study where ADSCs were combined with a type I collagen protein scaffold. They implanted this into rats that had severe radiation-induced vaginal injuries that mimic the human condition.
Here's where it gets really interesting. What actually happened to the scar tissue in those rats?
The treatment successfully promoted the regeneration of the vaginal epithelial cells and physically reversed the stenosis in contractures.
Wait, reversed it?
Yes. The scar tissue didn't just stop growing, the physical narrowing was reversed.
Imagine what this means for a patient. We aren't just managing the pain anymore. We aren't just handing someone a plastic dilator and telling them to forcefully stretch their own scar tissue so they can endure their next pelvic exam.
It's a completely different paradigm.
We are talking about literally reversing the fibrosis, returning the tissue to its pre-radiation state, or at least as close to it as biologically possible.
It is a complete paradigm shift. We're moving from a mechanical, symptom management standard of care to a molecular masterpiece. By understanding the specific anatomical vulnerability, that terminal blood supply of the distal vagina, we know exactly what needs to be fixed. We can use exosome-derived growth factors to command the body to sprout new capillary networks, clear out the inflammatory scar tissue, and ultimately give these cancer survivors their quality of life back.
If you're listening to this and wondering why your doctor hasn't offered this yet, it's because regenerative medicine takes time to move from these incredible animal models and early-stage trials into the daily standard of care.
That's very true.
But understanding that the damage is fundamentally cellular changes everything. It means the pain and the narrowing aren't just something you have to silently endure with plastic rods. It means regenerative biology is racing toward a biological solution that actually makes sense.
And that matters because knowledge is most valuable when applied. For anyone suffering from radiation toxicity, understanding that the damage is cellular offers profound, scientifically grounded hope. We are finally addressing the root cause, the microvascular desert, instead of just treating the symptom.
I want to leave you with a final thought to mull over. Something that really stuck with me as I was connecting the dots between these papers. If we can harness these exosomes to act as targeted biological care packages, if we can use them to reverse extreme radiation damage by rebuilding blood vessels from scratch and clearing out fibrotic scars, could we eventually administer these exosomes before the radiotherapy even begins?
Oh, wow. That is the ultimate goal, prophylactic regeneration.
Right. Could we proactively armor the healthy microvascular networks of the pelvis? Imagine a world where we deliver these exosomes alongside the radiation so that those terminal blood vessels never collapse, the tissue never starves, and vaginal stenosis never even has a chance to develop in the first place.
That would change oncology forever.
It really would. That, to me, sounds like the true future of precision medicine.